Thank you, sir, for that warm introduction. I asked God to relieve me of pain. He said, if I relieve you of pain, you will not remember me. Then I asked Him to give me all the luxuries, pleasures of life which I can enjoy. He said, I gave you life, you earn for yourself. Then I asked Him to give me some peace. He said, I can't give you that. You have to search within. But He was very kind enough. He said, I will give you some blessings. And He was very kind enough to sprinkle a seed of blessing on me. And that one seed was my teachers, Professor Dr. Shashank Joshi, O.P. Kapoor, and Dr. Prakash Kothari. God did not give me whatever I asked for, but in the teachings of my teachers, I got everything what I needed in life. And I thank all my teachers and beseech them to bless me always. My talk today is on female sexual dysfunctions and diabetes. In this next 25 minutes, I would like to give you some potent insights into this not talked about truth of human relationships. I would also like to give you some nuggets of wisdom into how you can improve the sex-starved lives of your patients to a better understanding and pleasure. Because I believe everyone's pleasure is their right and everyone's pleasure is their business. I am not from Congress, neither I am from Anna DMK. I am not from BJP or Shiv Sena or Aam Aadmi Party. I do not have any stakes in IPL. I am not a follower of Asharam Bapu, Shashi Tharoor or Digvijay Singh. I am not a penis genius. I am an Indian Medical Associationite and I have come here to ignite intimacy. When you are in love, wonders happen. And when you get married, you wonder what happened. At the beginning of marriage, every wife treats her husband as God, Pati Parmeshwar. But later on in marriage, somehow the alphabets change. James Prescott, the famous developmental neuropsychologist who studied 44 cultures across the globe, he came with his life conclusion that our brains have built-in reciprocal relationships between violence and pleasures. So if you want to decrease the violence at home or in your community or in the country, increase the number of pleasures. Men and women are two halves of humanity. He inside, she, man inside, woman, lad inside, lady, male inside, female, Adam inside, madam, Mr. inside, Mrs. The point here is, whether the problem in sexual relationship is with a man or a woman, the solution always lies in the couple. Our strongest need is pleasure, and the power to give pleasure is the greatest power we all have. Giving pleasure is the triumph of human spirit. There have been studies which prove that intimacy is very important for longevity. Intimacy is ageless, but we need to ignite intimacy, we need certain strategies for mind and body to have adequate or optimum sexual pleasure. And sex is the best prescription for good health, as suggested by American Heart Association and American Urologists Association, as they improve every system of our life. And it is also said, use it or lose it. Rishi Vatsayana in Kama Sutra clearly mentions sex is to be used and not abused. The whole puzzling thing about the human desire is that men and women tend to experience it differently. Let's unravel the blindfold. An unmarried girl with preconceived notions gets engaged, gets married, steps into the husband's house, spends the first night, goes for a honeymoon. Intimacy grows more deeply. She gets pregnant. And then a new life begins of motherhood. This is the big change in her life. And the issues after childbirth are, there are body image issues, there are cognitive distractions, and erotic focus changes. Women's health issues are always there from womb to tomb. as a toddler, as a girl, as an adolescent, as a mother, as a grandmother, and as she gets aged. It's a full of challenge always. Aging is inevitable. With the median age at last menstruation being 51 years today, life expectancy of women in developed countries is expected to exceed 70 years. And a large number of women spend substantial portion of their lives in the post-menopausal years. Physiological changes associated with the aging process, coupled with increased prevalence of medical disorders in old age, play a significant role in the pathogenesis of sexual dysfunctions. Hormones play a great role. Friends, diabetes is the biggest sexual health tsunami of our century. Every 8 seconds, a person dies of diabetes, and the same 8 seconds to develop diabetes. Now, this 8 seconds have been reduced to 6 seconds according to the IDF. There are 382 million diabetics across the world, and the sad thing is 1/3 of these diabetics are in India. India is almost the diabetes capital of the world, closely competing with China. So I call Chindia the diabetes capital of the world. It's a huge problem for women. Of the 382 million, half of these are women. And the WHO reports that 55% of diabetic deaths will occur in women. And it's going to be the 9th leading cause of death in women globally. The prevalence of diabetic women in 9 urban industrial locations as studied by the Industrial Population Study Group, the highest was shown in Trivandrum and the lowest in Assam. Dr. Seshaya studied pregnant women and found that they developed diabetes, gestational diabetes, as early as 16 weeks of gestation. The implications are women with history of gestational diabetes are at increased risk of future diabetes, predominantly type 2, and even their children can develop diabetes. So in our population, 33% of women who developed gestational diabetes had also maternal history of diabetes. So in gestational diabetes, there is a risk of miscarriage, stillbirth, premature birth, birth defects, excess fetal growth, complications in the mother of preeclampsia and the baby of hypoglycemia, and risks. So what is the female sexual response? And why do women have sex? They want to, as they desire, they want to have sexual pleasure or intimacy. They want to have children. They are expected to have sex. They are forced to have sex, or they are paid to have sex. Masters and Johnson was the first person in the history to define or to describe the sexual response. These lines represent excitement, plateau, and one orgasm. So a woman can be monoorgasmic, multi-orgasmic, or anorgasmic. But this sexual response was remodeled by Kaplan, who included a desire also. So now the traditional model, which we all study and we all work on it, is desire, arousal, and orgasm. So these are the 3 things which we work on. Female sexual dysfunctions involve any problem during any of these phases of the response. These include disorders of desire, arousal, and orgasm. They also include sexual pain disorders like dyspareunia and vaginismus. But in our culture, all across the globe, there has been total and absolute and persistent disregard for women's satisfaction. But Rishi Vatsayana in Kama Sutra clearly mentions that it's samabhog, mutual satisfaction, which is required for an optimal sex life. So what is desire? Sexual desire includes physiological, cognitive, and behavioral components, which is manifested by sexual thoughts, fantasies, interest in participation in activity, initiation of sexual activity, and receptivity of the partner approach. Arousal is the phase of sexual excitement which is manifested by pelvic congestion, lubrication, and swelling of the external genitalia. The physiology, there are a lot of hormones and neurotransmitters involved. Orgasm is a physiologic release of sexual tension associated with rhythmic contraction of perineal and reproductive organ and structures with cardiovascular and respiratory changes. The heart rate, respiratory rate, and blood pressure all rise mildly. Even in orgasm, there are hormones and lots of neurotransmitters which come into play. You can see here the dilatation of the whole vulva during the excitement and the plateau phase. And they again come back to normal. So there were 4 types of female sexual dysfunctions which are described. One is hypoactive sexual desire disorder, arousal disorder, orgasmic and pain disorders. The prevalence, according to Master and Johnson, across the world is 50% of all married women had female sexual dysfunctions, and 43% of these women were all in the early adult and geriatric years. So, female sexual problems all tend to coexist. There could be desire difficulties, there could be orgasmic difficulties, there could be pain, and there could be arousal dysfunction. The central effects are all hormone driven. The peripheral effects of sexual function are also hormone driven and neurotransmitter driven. So the tipping point or the sexual tipping point depends upon how the women get turned on and turned off. They get turned on by the presence of dopamine, norepinephrine, melatonin, oxytocin, estrogen, and testosterone. They get turned off by serotonin, prolactin, opioids, and progesterone. The dual control model also describes that patients can get excited if they are physiologically and they do not have any physiological or organic issues or psychosocial, cultural, behavioral issues. The definitions were not perfect, so they all worked on it. Newer consensus, according to the feminist perspectives, were designed, and they came in the newer Diagnostic and Statistical Manual of Mental Disorder, DSM-5, which came as early as May 17, 2013, in which the female sexual interest and arousal disorders were combined together and the pelvic pain disorders were. So the female hypoactive sexual disorders and arousal disorders were merged into female sexual interest and arousal disorders. Orgasmic disorders were unchanged, and this too were merged into genitopelvic pain or penetration disorders. This made life simple. What happens to sexual function in diabetic women? Our first study, which is one of the largest studies in KEM, with 56,342 patients, all were diabetics, we concluded that women were suffering from hypoactive sexual desire disorders and depression. Of the 24% women, 20% had hypertension, 44% had dyslipidemia, 46 were above BMI 30, 24 had coronary artery disease, and also were on antihypertensives, statins, and ecosporin. Most women did not complain and accepted that this as their fate. All women had mild to moderate depression along with the sexual desire disorders. Issues with diabetic women are either they have less or absent sexual desire, either they have less or absent lubrication, orgasm, or they have painful sex, vulvovaginitis, candidial infection, but depression was the commonest feature in all. The study done by my friend Fatemi says that scores in each domain of sexual functions were compared with those of 40 non-diabetic controls. Sexual function scores of for the sexual drive, arousal, vaginal lubrication, orgasm, and overall satisfaction domains were all lower in diabetic women with p-value of lower than 0.05. Amol, another friend, also studied the sexual dysfunctions in women, said that neuropathy, vascular impairment, and psychological complaints have been implicated in the pathogenesis of decreased libido, low arousability, decreased vaginal lubrication, orgasmic dysfunction, and dyspareunia amongst diabetic women. But when it comes to women in India, there is a benign neglect. They consider it to be sin to have sex, most of them, or they are tight-lipped. They don't want to discuss this. Amongst the Jordanian women, also the same thing we have observed. Increased glycemic control did produce sexual dysfunctions. Even in Nigerian population, it has been studied. And so diabetes, mellitus, and sexual function in middle-aged and older women have produced dysfunctions at all levels, desire, orgasmic, and at arousal levels. There are lots of studies, but this has been correlated, many studies, with various distressing situations, with natural menopause, surgical menopause, hypertension, arthritis, anxiety, thyroid problems, asthma, and here is diabetes, which shows that there is a decrease in desire, arousal, and orgasm, which is not there in any of the other chronic conditions. So how do we manage female sexual dysfunctions? This has to be first assessed by Placid model, cognitive and behavioral therapy, sex therapy, mindfulness. We control hyperglycemia, hypertension, dyslipidemia, and treat depression. The Placid model says that we have to obtain permission from the patient. Ask them, can I ask you something about your sex life? Is it okay with you? Then we give them a limited information, inform them about what is the normal sexual functioning. Then we give specific suggestions that we advise them to practice self-management of the whole thing. And then we give them intensive therapy. There are two questionnaires which we use in our practice. One is Female Sexual Function Index and one is Beck's Depression Index. We identify these problems, we screen them for depression, we send them for lab tests, and we also do their gynec examinations. So the treatment for female sexual dysfunction includes basic sexual counseling, lifestyle changes, pharmacotherapy, psychosexual therapy, which could be individual and couple, additional counseling of the partner if recommended, addressing comorbid depression, adjustment of medications and psychotropic drugs, and dilator treatment of vaginismus. Psychotherapy forms four types of treatment. One is Masters and Johnson sex therapy, mindfulness, cognitive behavioral therapy, and couples therapy. In Masters and Johnson sex therapy, we do not tell them how to do intercourse. We remove their wrong mindsets. We remove their attitudes which are not conducive to their sex life. We improve their communication skills. We encourage them to speak to each other about their needs. We try and remove the misunderstandings and myths and encourage partners to express their thoughts and emotions. Sensate focus exercises which are very important. We teach them how to do this. Mindfulness training is now a new form of therapy which is in vogue. During sex, mindfulness can increase attention, increase awareness in the present moment of the body, can decrease distraction, decrease anxiety, increase relaxation, increase connection with the partner and body, and decrease self-judgment. So many women find it difficult to get in the mood for being sensual and sexual when they are feeling tense, worried, or distracted. It's easy to let our minds become filled with everyday worries such as who's picking up the kids tomorrow, how will I finish the report in time, and so on and so on. Recent research has shown that these worries and distractions can really inhibit sexual arousal and enjoyment. Therefore, it is important to find ways to stay in the moment during sexual experiences. Mindfulness exercises are a special type of relaxation techniques that can help you stay in the present moment and experience more pleasurable sensations during sex. And online, the CBT program of Pursuing Pleasure program is available if anybody wants to go through it. The other side is cognitive behavioral therapy, wherein we try and change the maladaptive thoughts and repetitive thoughts of the patients. We change unreasonable expectations. We discuss norms and values about sex, and we focus on information about sexuality. Changes in thoughts, attitudes, behavior lead not only to change feelings, but may also affect sexual physiology, and changes in sexual physiology can lead to the other things. Couples therapy is very important. We focus on the dynamics of the couple. We help them communicate to each other. We try giving no pressures from each partner. We restore physical affections. We increase their emotional intimacy, and we develop and try and imbibe a feeling of trust and respect amongst each other. The pharmacological treatment includes giving hormones, giving PDE5 inhibitors, newer things like fibanserine, Botox for pain things, herbal agents, and bupropion for depression. But before that, we must see that we try and control hyperglycemia, hypertension, dyslipidemia, and obesity. If these women are on hypertension, if they are on diuretics, we prefer giving them indapamide, which is safe. If they are on beta blockers, we try giving them nebivolol. If ORBs, olmesartan, is said to be sex neutral. Testosterone was tried in 814 women of the age of 20 to 70 with all diabetics leading to menopausal and hypoactive sexual disorder. The treatment was for 24 weeks, and we found that 239 postmenopausal women with climactic symptoms, and we put them on transdermal estrogens, they had very good improvement in sexual functions. They increased their sexual activity, enjoyment, lubrication, and sexual thoughts and fantasies. There was less pain, but there was no effect on orgasms. Local estrogen supplementations increased arousal and decreased dyspareunia. 2 years ago, we started a program called Mindfulness Exercises, which is a 3-month program. We train women to meditate, 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 38 menopausal diabetic women between the 46 and 64 years with more sexual problems after the menopause were studied. No HRT was given. Tibolon 2.5 milligram for 3 months improved their sexual fantasy, arousability, and desire compared to the placebo. There was significant decrease in sex hormone binding globulin. PDE5 inhibitors, it is tried. But what is the rationale? There is definitely genital engorgement and it does increase the vaginal blood flow. Sildenafil enhanced the blood flow in open label studies in healthy females and in females with arousal problems, but without convincing effects on the subjective feeling of it. There was inconsistent result on improved sexual responses by sildenafil in many randomized control studies. So this is not yet recommended, or there is less evidence base for giving sildenafil in women. Sildenafil was also tried in patients who had depression. So depression associated with sexual dysfunction, 98 women with 18 to 50 years who were on SSRIs, induced sexual dysfunction, orgasm, they also did not improve much. Botox is tried in vaginismus. What are the future things available? Fibanserin in 5-HT1A serotonin receptor agonist and 5-HT2A serotonin receptor antagonist is tried. There have a lot of been studies and they show that they improve desire, arousal and orgasms. The other strategies which are now tried are combination of testosterone with 5-HT1 agonist increases the drive from testosterone combined with the reduced inhibitions. Testosterone with PDE5 inhibitors also is tried and also shows some positive results. So the algorithm we all will come to later. We have to compensate for normal aging changes in women. We have to provide them teachings on normal aging. They make them understand that, accept the reality, discuss the need for longer foreplay during their arousals to compensate for normal aging changes. Consider alternate forms of intimacy when sexual intercourse is too uncomfortable or not possible. And it is said, use it or lose it. In a multicentric double-blind randomized placebo-controlled study of 305 diabetic women with symptoms of vaginal atrophy were treated with low-dose synthetic conjugated estrogen A cream twice weekly. The results indicated the cream was effective compared with placebo in treating vaginal atrophy, including pain. Depression, it's a catch situation. Treatment of depression may help to improve libido and sexual dysfunction such as orgasmic disorder. However, medications to treat depression often impact sexual function by lowering libido and causing orgasmic disorder. So bupropion is tried in depression-related sexual dysfunction. There was a beautiful article and a review study. This was the first antidepressant medication which showed efficacy but had many side effects which compromised the patient's adherence to treatment. Since 1985, even before its official release, bupropion has been studied as a treatment for depression with the benefit but with less impact on sexual function. Even Medscape mentions all that. So, for normal sexual desire with normal or high motivation, we need to assess the hormone profile, androgens and prolactin first. It could be the libido issue or the libidinal dysfunctions. If the normal and high sex drive is there, but the motivation is low, you should assess the quality of intimacy and relationship. Then the interpersonal relationship has to be done by sex therapy and counseling. If they have low sexual desire and low motivation, we should assess them for depression and biological or other relationship factors. So we have to optimize treatment by giving them not only pharmacological treatment but combine everything, sex therapy, CBT. We have to learn to remove how to improve their relations and remove the risk factors. All couples who are diabetic need touch. Touch promotes sensual smart. Our society considers as a body image is very important. This myth has to be. Feminism has to be adored and respected. If we adore and respect feminism, there will be less quarrels, less war. Look what Mahabharata is all about. Break the monotony. Sex has many dynamics and we are all hardwired. The rich and famous all cheated on each other. If we keep on ignoring and minimizing our partners, we'll try to build up wall between each other, and this wall will increase. If the women try to correct all the time and ignore and criticize their husband, there'll be a wall which will build. But if you dismantle one brick of this, there'll be a ray of light, and slowly by communicating and appreciating each other, you can dismantle the whole wall. Don't have any expectations when you go in the bedroom. Learn to give and learn to accept. Diabetic women who don't get enough affectionate physical contact suffer from depressions. So for conjugal life, constant connect is a must. Alternative things can be tried instead of coitus. Sex education, but sadly, sex education is not yet taught, and our minister did not agree to it. What is sex education? We need sex education in sexual sciences to eradicate the damaging, superstitious myths and misinformation. We need sex education in sexual arts to improve our erotic lives and keep our families intact. We need sex education in sexual psychology and philosophy to determine our true sexual nature. But our ex-minister banned sexual education in the school. So the onus is on us. We should ask our patients, do you have problems in love? We ask histories of allergies, surgeries, addictions, but this also is very important for us to ask. Look for our inner beauty. Don't change her, change yourself. Try new things in bed. Express spontaneity. Variety is the spice of life. Do everything what you can. Husbands watch porn and wife work in the kitchen. What are you giving? What signals are you passing? You are giving her a signal that you like the girl in the movie more than her. Instead, watch the porn together, get excited, and criticize the girl in the movie more. So you'll get. After play, men don't have any concern. Once they ejaculate, they turn themselves on the other side and sleep. They use their partners as sleeping pill, which is so wrong. Once you have ejaculated, you should hug her tight, hold her, kiss her, thank her, compliment her, tell her she was awesome, she did a wonderful job. This is required. If you see any beautiful girl, anybody would tell her she is gorgeous. But if you are complimenting and thanking your partner in the bedroom in that state, you are giving her a signal that you like her the way she is, which speaks miles. This increases the commitment between you. If your wife is silent, it's the biggest cry. Avoid smoking. You are what you eat and what you drink. Don't let your stomach be a dustbin. Come khao, gum khao. This is Jainism what they say. Workout. Commitment is very important. Commitment is the biggest, most marriage mileage. Accept the way you are. Love each other unconditionally. Increase the romance. Bring in harmony. These all women were abandoned by their husband. They got a makeover done and they were again adored and admired and be together now. Get charged. Nothing wrong. Bipasha comes to my clinic. I get charged, but I don't tell her. But nothing wrong in that. But you must see that you discharge in your wife. That's very important. Focus on changing yourself. Don't take off your headphones. See, if you are telling your child who's already on the headphones, you get irritated. So you don't become that headphone for your partner. Try and understand her feelings. Practice humility, which is important. It's not just about love. It's about understanding each other. Unless we love and are loved, we all are alone in this world. And that which divides us is the mind itself. So the key to having good relationship or having good female sexual health is give undivided attention to your partner. Give her quality time. Trust, adjust, be communicable, don't compare. It's not about reproduction or recreation. It's all about relationship. What is it? Friends, life is nothing but a sexually transmitted gift with 100% mortality. Every wife is a mistress for her husband. Miss for 1 hour, dress for the rest 23 hours. But the origin of a child is a mother, a woman. She shows a man what sharing, caring and loving is all about. That is an essence of a woman. A woman is one of the most beautiful phenomenon in the world, not to be compared with anything else. A woman is the best masterpiece of God. The language which she understands is communication and romance, and men will understand only sex. Friends, diabetes is not an option, not for anyone. It is how gracefully we handle the process of diabetes and how lucky we are as the process handles us. So my last slide is, female sexual dysfunction is highly prevalent and undertreated problem in diabetics. By addressing the physical, psychological and couple factors, physicians can play a major role in helping their patients enjoy improved sexual function and increased self-esteem. Sensitivity of the physician in approaching the problem is very important. Sympathetic approach along with relevant treatment, these women will go a long way in improving their sex-starved lives. Aging is inevitable and friends, sex has no starved expiry date. Thank you all for your love.